Hello and welcome to our last webinar of 2020, which, yay! This evening we've got a fantastic group of people here for you guys to listen to and to ask questions to. Just so that you know, what we're going to do is we're going to have a little bit of a running order. We're going to have the amazing Darlene from A Perfect Match. Do you want to wave, Darlene? We're going to have Rich Vaughan from International Fertility Law Group.
Everybody.
And then obviously you've got Dr. Danishmand and myself from SDFC. We're going to start talking a little bit about COVID and the implications of COVID on surrogacy, IVF, and the whole process in us and life. I mean, 2020 has been, let's say, a year I would not like to repeat. And I haven't even had COVID, but it's obviously had a massive impact on us. It's had a massive impact on people looking to go through IVF and also surrogates, people who are willing to carry for us egg donors. So we're going to talk about that. After the impact of COVID, I'm going to open up the floor for questions. On your panel, on your control panel, you should be able to ask questions. So if you write a question, I will make sure that it is answered by one of the panelists, okay? After that, we're then going to talk through the normal process in a non-COVID world. So assuming you've been vaccinated, which hopefully, apparently I'm going to get mine in April, we can then talk through how that works, and then we'll finish off with some questions as well. So remember, on your control panel, there is a section where you can write us a question. Please write it. I will make sure it's answered. So I'm going to turn over to our amazing panelists. First of all, do you want to introduce yourself a little bit? And then we can delve into surrogacy, IVF, and COVID. Ladies first, Darlene, would you like
ladies
to
first, thank you. My name is Darlene Pinkerton. I am the founder and CEO of A Perfect Match, which is located in San Diego, and it's an egg donor and surrogacy agency. We've been incorporated since 2000. So we've been around for a long time. I've worked with all these gentlemen for a long time as well. We've all been in the field for a long time. And I'm located maybe 15 minutes from Dr. Danishmand. So enjoy a great relationship with him. Thank you.
Brilliant. Mr. Vaughan.
Hi, everybody. My name is Richard Vaughan. I am the CEO and founder of International Fertility Law Group. I'm also a parent through egg donation and surrogacy. And I've been in practice since 1993 as an attorney, but in this field specifically since 2006. I've also been the chair of the American Bar Association Assisted Reproduction Committee for a number of years, helping push through some policy and model legislation in this area, both nationally and internationally.
And you have a great first name. Dr. D.
I'm Dr. Saeed Danishmand. I have been in practice for about 22 and a half years. Really have had the honor of accompanying many intended parents around the world in their journey to creating their families. I've also been involved in many research and publication projects, really the goal of which has been to improve the success of IVF in vitro fertilization and improve the safety. And I've really had the honor of working with this particular team for many years. It's been really an honor because they have, I can't think of a team that's more passionate, more professional, really more caring about what they do than the team that you see before you. So I'm very excited to be here.
Thank you.
And for those of you that don't know me, I think most of the people on this webinar do. My name is Richard Westerby. I, like Rich Vaughan, am a father of two, born through IVF and surrogacy in the United States. And I work for the 5 doctors that we have at SDFC. So we've got Dr. Danishmand and then some of the others, which I believe some of you have worked with or are working with at SDFC too. So welcome. And I can't reiterate it enough. This is our last webinar of 2020. I mean, it's something that I never thought would make me smile as much as it is. Anyway, so moving briefly on from that, COVID has been disastrous for many people. It forced the closure of many businesses. In fact, it forced our doors closed for about 3 to 4 weeks in March, when the world basically fell over. I think it would be best really if Dr. D, you started with this bit, because obviously the IVF part is obviously the egg, the sperm, the bit that where the whole process starts, right? So if we start with the medical, how has COVID affected IVF? How has COVID affected egg donation, surrogacy, and our business? And what are we doing to help people navigate the, I hate to say it, the new normal?
You know, I've been really proud of the way in which the scientific community has approached this pandemic, because really it's been the response that has led us to this particular point, which is, you know, the generation of vaccines and really a way out of this particular tunnel. Because the way out of any pandemic, there's only one way, and that is herd immunity. And you achieve herd immunity either by infection or by a vaccine. So I'm really proud, and I've been really following the research and the publications, the studies that have been published in the field. When initially the pandemic was started, we didn't have a great deal of information as to how it affected in vitro fertilization, eggs, sperm, embryos, or the pregnancy. We felt that based on extrapolated data from other viruses, other coronaviruses, that we felt that there was no really evidence of vertical transmission, but we didn't have studies to prove it. We also didn't feel that it was going to have a major impact on sperm, eggs, or embryos, because in the field of IVF, IVF has been around since 1978. There's never been a case of transmission of viruses or bacteria from the sperm, from the eggs to the embryo, and subsequently to the patient who's pregnant. So we were fairly confident, but we needed studies to prove it. And studies did come, and they came fast. Studies in the US and Europe, in many parts of the world, that showed, number one, that there was no evidence of vertical transmission from the mother to the fetus, no evidence of any malformations. And also, it gave us some comfort that the majority of pregnant patients who tested positive for COVID had either mild symptoms or were asymptomatic. In fact, one particular study out of Columbia University showed that 88% of patients who tested positive and who were pregnant either had mild symptoms or no symptoms. So the data on COVID-19 has been very reassuring. The latest data is about, or latest questions are about whether the vaccine should be administered, you know, to patients who are contemplating a pregnancy or those who are pregnant. All of the medical societies in the United States have come out with a joint statement saying that the messenger RNA vaccines that are currently available, which is the ones from BioNTech and from Pfizer, jointly produced, and from Moderna, these messenger RNA vaccines should be safe during pregnancy and should be safe for all of those who are contemplating a pregnancy, and also for breastfeeding women as well. And the reason for that is because the mechanics, the platforms, the way in which it works by generating a protein in the body, and that protein then elicits an antibody response and creates antibodies. Actually, a messenger RNA becomes degraded in the body very quickly by natural, normal cellular processes, so that it should be safe. And again, the American Society of Reproductive Medicine, the American College of Obstetricians and Gynecologists, the Society for Fetal Medicine in the United States has come out with a joint statement stating that this should be offered to pregnant patients. So the data has been reassuring. And of course, we've had to pivot as a fertility center. Right now, for example, we're freezing sperm with colleagues in Europe. There are many things that we're doing. I was just speaking to a German couple in regards to not only freezing sperm, but also finding a way for that particular couple to come to the United States to achieve their IVF cycle as well. So there are many things that we can do, many solutions, and really, were it not for the help of colleagues around the world, the incredible efforts of Richard Westerby, who has been working hard in Europe on our behalf, none of this would be happening. Linda, our IVF lab manager here, it's a team effort, and you really understand the quality and the dedication of your team when there is a crisis like the pandemic that occurs, where we have to pivot and find solutions to help intended parents continue with their journeys.
Yeah, thanks, Dr. C. And actually, a question that has just come up is talking about sperm freezing in Europe. Just very quickly, we are working with clinics around Europe that are helping us with the sperm freezing. It's not easy, and obviously it's a third party, so we're working with other clinics. But if you want to talk more about that with me via email, we can do that. Basically, the way it works is the clinic in Europe will do exactly what you would have to do if you were in the United States. And we have to do blood and urine work. They speed freeze the sperm. And if you've got eggs or embryos frozen as well, we can do the same thing and ship those over. It takes time, and it's not like, oh, I'll just do this tomorrow. There's a whole process, as Dr. D just said, but we've done it. I've spent the past 7 months navigating it. We can work you through it. So, Darlene, do you want to touch a little bit upon how COVID has affected surrogacy? And I'm seeing the questions coming in. I will get to the questions, so don't panic. But Darlene, do you want to just jump in a little bit on that, on your side?
Of course. COVID has definitely hit the surrogacy world on a personal level because we have stay-at-home orders, and the surrogates are doing homeschooling with their children. And so what we're actually seeing is that surrogates are kind of delaying doing this right now until it's figured out with their children, because the responsibility of taking care of a family and potentially having any kind of bed rest or anything is a lot for them to think about right now. We've also been talking, Rich Vaughn and I have been speaking a lot about the contracts, and we're finding that we have to put different language now in the legal agreements. And part of it is, you know, that the surrogate has to follow IVF clinic guidelines, certainly CDC and stuff, but also what happens if they have to travel? And, you know, a lot of surrogates don't want to travel right now. They're concerned about getting COVID somewhere in their travels. So we find that we're working much closer with more localized surrogates to clinics. And fortunately for me, we do Southern California primarily. So, you know, that hasn't really stopped us from being able to do cycles. But, you know, just having parents and surrogates be on the same page of how to have the surrogate, is she going to stop working? We've had some parents ask surrogates to stop working. Not all of them can. Talking about vaccines, we have to make sure that the parents and the surrogate are both on the same page about that, because we have, it's hard to believe, but we do have some parents who don't want the surrogate to have vaccine, and the surrogate does want the vaccine. So that's where Rich Vaughn and I have been working closer together about language that we can have put into an agreement where everyone is more comfortable and is on the same page before we go much further with a match.
And actually, Darlene, you the questions that have come through are the following. First of all, one of them is, and these are specific COVID questions, so I'm going to bring these up. One of them just says on British TV, basically the European authorization for Pfizer has said that it's not good. There's one objection for pregnancy because of risk of an autoimmune reaction. In the UK, they've said the vaccine should not be given to pregnant women or women who are planning to become pregnant because it's not secured. Nobody knows the side effects. Do surrogates get the vaccine? You know, these are great questions that a lot of people are very worried about. And I guess, you know, Dr. D, you're the doctor, right? So do you want to just very quickly jump on that, and then Rich, we'll go to you, because I think that kind of followed on.
I just want to say one quick thing about this conversation about vaccines, because there are other vaccines that have always been a part of our planning, and sometimes this question comes up with measles, mumps, rubella, all the other vaccines too. So I just want to point that out. Go ahead, Said. Sorry.
I just want to say that all of these particular issues and questions and concerns have always plagued vaccines all the way back to the polio vaccine. The polio vaccine essentially eliminated polio globally. But did it have side effects? Absolutely. In fact, there were some deaths. 11 children died as a result of the polio vaccine. So We do have information on the side effects of the vaccine. There were 44,000 participants in the Pfizer BioNTech trial. There were 33,000 in the Moderna trial. So that's information on close to 80,000 participants. So we know the side effects, and we know how it works. Now, does it have side effects? Absolutely, it can have side effects. It can have short-term side effects that we know of, and potentially there may be unknown long-term side effects. But if you compare it to the side effects and potential implications of the COVID-19 infection, then really the vaccine is infinitely a better idea. They're in the Pfizer BioNTech trial, because of the large group of participants, 44,000 that were enrolled, there were many who actually became pregnant during the time of the vaccination, the first and second. And Pfizer has promised to follow up on that particular subset of data very soon in the coming weeks.
Right.
The issue of autoimmunity has always plagued every medication, every vaccine. That's something that can potentially occur. But when you look at these large trials that included thousands and thousands of patients, they did not see any autoimmune reactions that were significant for us to be concerned at this particular point. The American Society of Reproductive Medicine, the Society of the American College of Obstetricians and Gynecologists, the Society for Fetal Medicine, have looked at the data, have analyzed it, and they believe at this particular point that it should be offered to those who are contemplating a pregnancy or to those who are pregnant. And part of the reason is because if you're pregnant and you're looking at the vaccine and the potential side effects, short-term side effects, and you're looking at the COVID-19 infection and potential complications and side effects, then again, the vaccine is really a very clear option for all patients. And it's really the only way out of this pandemic for us, unless we adopt a policy, for example, of herd immunity through just infections. And that obviously has a significant risk, both in the short-term, long-term risk of, as you know, sometimes patients with COVID infections can have longer-term effects. So I don't see at this particular point from a scientific perspective any reason to adopt a policy that the UK has. The UK is just saying not so much that the vaccine is not good for pregnant patients. The UK has stated that we need more data on pregnancy and on patients who plan to become pregnant before we adopt a policy recommending it. And that's fine. And that's a reasonable policy. And that data, I think part of that data will come with the Pfizer trial and the subset of patients who actually became pregnant during that vaccination period time.
Okay, so I think it's...
Can I add something to this?
Yes.
So first of all, Dr. Donishman, thank you. You know that we rely on you in our community for updates on all of this. I want to say that parents are very cautious right now. And so we are finding that people want to, if the surrogate is going to have the vaccine, they want to see her have both doses before she begins any of the process to do an embryo transfer. And so again, that comes to legal, where we talk about how to hold a surrogate for a period of time while she does that and make sure that she doesn't have any of those side effects. And so, for our German clients, I just want you to know that we are doing things as an agency, as attorneys, as doctors, to try to keep this as safe as we can. And if you want to delay a cycle based on this, it does not mean you can't select a surrogate and have everything in place and be ready to go. So I just want to encourage you in that there are options.
And you actually took the question out of my mouth that I was going to ask Rich. And so legally, obviously, Rich, both you and I have done this, right? We've lived the roller coaster of becoming a parent through IVF and surrogacy and everything that it works. And I remember me, exactly as Darlene said, is like, I wanted to make sure everything could be done so that there were no risks, like mitigate everything. from a legal perspective, you know, if I came to you and said, I don't want my surrogate to do the vaccine whilst we're trying to get pregnant, what can I do? Can she do it before? Do it? You know, how would that work?
Well, there's a couple of things I'd like to say before addressing that specific question, and that is to say that COVID is an obstacle, but it's one of several. And for many parents going through this process, you've already been through quite a bit to get here. This is just another obstacle. It's, to use your analogy, it's another it's another hill on the roller coaster, but you'll get over it, and then it'll, you know, it'll go fast after that. So what's really important is working with your team, and we've got a great team here on the webinar, but your team will get you through it. As far as the legal issues, you know, we do have new language that we've added to the contracts where the parties have requested. Most of all, it's important to understand that in all of these contracts, even without COVID specific language, the language says that the surrogate must follow the doctor's orders. I'm not a doctor, the agency's not a doctor, so the contract really isn't going to be giving out a lot of medical advice. If we do state something in the contract about COVID, it usually is along the lines of everyone's aware that there's an outbreak. There are lots of guidelines. Surrogate agrees to follow her doctor's orders as to which guidelines apply. The issue we have here in the US is that we've got CDC guidelines, we have state health department guidelines, we have county health department guidelines and city health department guidelines, and lockdowns and quarantines and curfews, and it's always changing. So if we try to get too specific in the contract, it will just, that will be another obstacle unto itself. That contract will never be signed. So we try to be reasonable in the language we add in the contract. But on the issue of vaccine, you know, the surrogate determines, it's her body. She has the ultimate right to decide whether she's taking or not taking the vaccine. We cannot force her, even if we said it in the contract. We couldn't run into court, wave that contract in the judge's face and say, make her fill in the blank. We can't. So we have to honor and respect that fact. It's a healthy balance between the fact that it's your baby as an intended parent, but it's her body. And so we have to respect both sides of that equation.
I also want to say I have had surrogates that did get COVID while they were pregnant. And as Dr. Donishman said, their symptoms were pretty mild. They've all given birth since that point, and the children are all fine. So we've not seen where someone who did get COVID during the pregnancy had a bad outcome. Still, you don't want to, you know, if you can mitigate a risk, why not? So,
and I think to Darlene's point, I think to Darlene's point, it's important to know, and to Rich's point as well, is that there is patient autonomy. So that we're not obligating any patients to take the vaccine. It's just something that is offered, and really it's the patients, the intended parents with the surrogate. Of course, it's the surrogate's choice, but it's certainly a point of discussion between the intended parents and the surrogate. And certainly for all of our patients, you know, for our team, you know, for every one of us individually, it's going to be a choice whether we take the jab or not, to use the English term for vaccination.
it's a good one.
It's a good one. And but it's our choice. And it's also true that the messenger RNA vaccination, and especially to this in terms of the global studies that have been done, this is the real first implementation of a messenger RNA vaccine to this extent. There have been others, namely there was some in the Ebola infection time period, but really this is the first one that's being adopted to this level. And there are going to be unknown potential effects that we just don't know of until potentially years and years after the vaccination regimens.
How to scare everybody.
I'm sorry, I didn't mean to interrupt you. What I wanted to also say is we have to remember the surrogates are probably in the last group of people that are going to get vaccines. You know, because if they're pregnant, that's a different story. But those who are just starting the process, who are just matched, they're not going to be looking at least not in California or in the United States. They're looking at what, maybe fall, Dr. D, at the earliest?
Well, I mean, Yeah, I think it's really going to depend on how many vaccines will be on the market. Right now, for example, we had a second vaccine, Moderna vaccine, that was approved here in the US, and it's going to be about 20 million doses before the end of the year that are going to be available. In January, we're going to probably be hearing from many other companies, including Johnson & Johnson, that probably will have their vaccine rolled out by sometime in February or March. So we're going to be at a point in the springtime when potentially there may be at least 10 different vaccines on the market. Now, some are with novel technologies like the messenger RNA, others like the AstraZeneca Oxford vaccine, which uses a slightly different, in fact, it uses a attenuated virus to introduce the protein into the body, and then others that have used the traditional vaccinations. You know, for example, the flu vaccine is a vaccine which is an attenuated virus itself. So it really depends. That some of the projections, for example, in the US are that by April of 2021, there could be as many as 100 million people vaccinated here, which is just slightly under 1/3 of the population. And that could be the same in many other countries. It depends on the regulatory bodies in each particular country. There are many countries, for example, in the Middle East that have started their vaccinations several weeks ago, because there is the Sinovac Chinese vaccine, there's a Sputnik 5 Russian vaccine that's being given both in the Middle East and in Asia to many countries. So there is sort of this global vaccination effort. And I just heard on the news last night that China is going to be opening up a very large plant just to develop and manufacture the messenger RNA vaccine. So I think that we're going to see at least 10 different companies come out with very reliable vaccines over the next coming months.
Brilliant, thank you. I think, so Rich, just some of the other implications that this has brought about. For example, what happens if we can't get in when our child is born from a legal perspective? Who's going to, is there a guardian? How does that work? And how do you, I mean, we've done many webinars actually on how you're helping people get into the US, but very briefly, how are you helping people get into the States and all of just that part, which I know is something that is, you know, we're worried about, obviously by the time this happens, we might have a vaccine, but even still.
Right, so under the current travel bans pursuant to the presidential proclamation, there are a number of people from certain parts of the world that are supposed to not be entering the US. These proclamations were issued at a time when there were high-risk spikes in certain countries, and of course now it's everywhere, but these proclamations still exist as of today. They may change, we don't know. But in the meantime, the first thing to do is to plan for the possibility, as remote as it is, you might not be able to get here. So to have a temporary guardian that you've thought about who could get to the hospital just in case you can't. But I will say every single person that we've applied for an exception to these travel bans has been approved. Every single person who's wanted to get here has gotten here. So I wouldn't worry too much, but you know, just be prepared with at least a temporary guardianship appointment of someone here who can take care of your child if you can't get here. The other thing is just to be prepared for these travel authorizations. If you're in an area subject to the presidential proclamations, you need to get permission to travel. There are two exceptions to the travel bans that would allow people to get here that would be most applicable in these surrogacy situations. One is if you are the parent or guardian of a US citizen child age 21 or under. So if you already have a US citizen child, maybe from a prior surrogacy, you're automatically allowed to travel. You just need to have a copy of the child's passport, the bio page part of the passport, and the child's birth certificate with you when you're traveling. And you don't have to travel with the child. You can if you wish, but you don't have to. If that exception doesn't apply, then the other one is a national interest exception. And the argument with this exception is that it is in the national interest of the US that you be allowed to get here to make medical decisions for your child and take custody of your child, take the child from the hospital when the child is ready to go, so that the US healthcare resources are not further burdened during this pandemic when we need all of the healthcare resources that we can get. That approval has worked, or that exception has worked for many. for most who've needed it, or all who've needed it, I should say. And the exceptions are typically good for 30 days once granted. And the way you get the exception is you petition the embassy, the US embassy that's closest to you, to review your file. And you do need a file. There's a number of documents that we prepare, but if everything's in order, the permission comes rather quickly, and you're allowed to travel. And we typically want you thinking about traveling here 4 weeks prior to the birth, so that you have some time to quarantine, first of all, and that you also are here just in case the birth occurs early. The other thing to think about and just be mindful of is that the pandemic has caused hospitals to continuously evaluate and reevaluate their policies on who can be inside the hospital during the pandemic, or who can be in the delivery room. And that's not something we can predict even 2 weeks out, because that policy might change 2 weeks from now. So it's something you have to look at immediately before you're traveling, and just be prepared for the small possibility you may not be able to be in the delivery room, and it's nothing we can change. Again, we can't force them, we can't sue them, we can't get a judge to make them let you in. This is a matter of public health, so they're allowed to set those policies.
I can address that a tiny bit. So in our experience, what we're finding is the hospitals are basically taking the parent's phone number and having them stay in the parking lot until the child is born. And then they are allowing them in, but they're not allowing anyone more than maybe the husband of the surrogate, if even then. We've had a number of hospitals refuse to even allow them to have any support person with them during the birth. We've had other hospitals that have allowed the parents in. So what Rich is saying is, this varies from hospital to hospital, and until it's time for the birth, we don't really know what that hospital is going to say. Rich, I would ask you if you would please address what we're finding is not that we're having trouble getting parents here, we're having trouble getting parents back out. And it has to do with the fact that vital records offices are either on limited hours or closed. So can you address that, please?
Sure. So at the beginning of the pandemic, the US State Department closed down its passport offices, and passport processing was done by mail, and it would take up to 4 months, 16 weeks to get a passport. That was not tenable for most clients who needed to get back home across borders. So many countries came to the rescue and would grant either a home country passport or an emergency travel document of some kind. In Europe, it's typically referred to as a laissez-passer. That would allow the baby to travel home even if they couldn't get the passport. But usually before the passport, you've got the birth certificate issue. And birth certificates normally take several weeks, 2 to 3 months, because it starts off getting registered at the local county level, then back up to the state level, then back to the county recorder's office. We can get them expedited, and usually that's 2 to 3 weeks. But during the pandemic, it's been uncertain. So that's another potential unknown that we have to deal with, and it could be a little bit longer. In some cases, it was faster, which was strange because everybody was working from home and they didn't have to deal with as much daily interruptions with people coming to the front desk, asking for their documents. So again, it's just county by county as to how fast those birth certificates can be made available. Once you get the birth certificate, then you need either to get a US passport, which now, thankfully, the processing is back down to 10 days. So that's not so bad. Or you get the home country passport or emergency travel document, which might also require that you get your birth certificate, possibly your court judgment, apostilled. That's a stamp from the Secretary of State in each state that would verify the document as authentic. So that can take a little time to get too. Sometimes the Secretary of State's offices have been closed and only handling things by mail. So there's a number of things, all manageable. It just takes a little bit more time and patience.
A little more effort.
The moral of the story, or the thing that we need to think, is dynamic. This is a changing environment. We just need to change. Which obviously when you're trying to create a family is one of the things that is least on the list. There is a question that's come up saying, will there be an obligation to be vaccinated before entering the US for the birth of the child? We don't know yet. That I guess that's, again, there isn't one at the moment, but having England going into lockdown and becoming the super spreader of the new strain, think we're going to find out pretty soon what the travel into the States is going to be like. But anyway,
I think, yeah, and one of the interesting concepts that airlines are now trying is this sort of a tunnel, tunnel between different countries. For example, it's happening between New York and Amsterdam, in New York and Rome, meaning that you go to the airport, you get a fast COVID-19 test, a rapid COVID-19 test. If it's negative, you're able to board the plane. Once you board the plane and you, let's say, land in Amsterdam, then you're taken to a particular consultation room, ask questions, and then they do another test on you. You quarantine for 24, 48 hours until that particular PCR test results are out. And if they're out, then you can go back into sort of society and go about your business. So I think airlines are trying this very scientifically based sort of tunnels, health tunnels between different countries. And I have a feeling that that's going to be the sort of the modus operandi moving into 2021 until a time potentially when there's been enough vaccinations.
Yeah, I agree. Okay, so I think that was the last question re-COVID. Again, if anybody...
I do see one. Does Surrogate get the vaccine? Can we explicitly ask for a surrogate which doesn't have the vaccine?
Oh, I think that must be to you directly. It didn't come to me.
Oh, is that to me?
I see it as well.
I would have just...
Okay. Any of you see a question that I haven't answered?
Okay. Well, so I will address that question. The answer is yes, absolutely. A match has to work for all the parties. And so if you don't want your surrogate to have a vaccine, that's who we would find for you, is a surrogate who will not get the vaccine. And it's vice versa. If somebody wants a surrogate who's willing to get the vaccine, then that's what we would find for them as well. But you have absolute right to make that decision for yourself, for your baby, and we will match you with a surrogate who's like-minded. Hope that helped answer.
That's a good point. Good point.
Great question. Thank you guys for the questions as well. Please do keep them coming. I think what would be great now is obviously we've dealt with a bit of that, but maybe high level, let's now talk about the IVF process, the surrogacy process, and then the legal process. On a normal day, how would we be operating? And I feel that way because that, again, you're starting with the medical bit and going through. So Dr. D, do you want to jump in and talk about IVF and what you do?
Absolutely. I think many of you may have already heard, me talk about this, but really I'd just like to always divide it into sort of three different parts in terms of the surrogacy journey. You have the sperm, you have either the egg donor or the egg provider, and you have the surrogate. So for intended fathers who are going to be working with a surrogate and an egg donor, as Richard had said, we have colleagues in Europe where we can freeze your sperm, do the FDA infectious disease testing, and then transport the sperm to us. Then after that, after the sperm is transported, what happens is that you choose your egg donor. And as you know, we have our own egg donor database. If you don't find your ideal egg donor database, actually, I think you should definitely look at our colleagues at Perfect Match. They have a wonderful egg donor database. So you have really two egg donor databases at your disposal. And once you've now chosen your egg donor and she's done all her screening and all the testing that she needs to do, psychological testing, genetic screening, egg quality testing, once that's all been done and we have the sperm, then we can create your embryos. Remember, your egg donor goes through medications to stimulate the ovaries, we mature and develop eggs. We retrieve those eggs, fertilize them, let them develop over the course of 5 days. And again, many of you have seen these images. That's a typical egg right there. That's a fertilized egg. And then the embryo divides into 2 cells, into 4, into 8, into 16. And then after 5 days into the stage called the blastocyst stage. And at this stage, we freeze the embryos, and we can also do the chromosome testing on the embryos prior to freezing the embryos to look for chromosomal abnormalities like Down syndrome. No difference between fresh and frozen embryos in terms of pregnancy success rates or the health of children. So now we have embryos that are frozen. For those of you who are going through an IVF cycle, for our heterosexual couples going through an IVF cycle, we'll arrange for you to travel to us. We've found different solutions. I think Rich has alluded to several of them, but you'll come here for the egg retrieval for the creation of the embryos. Now the embryos are frozen, and then we're waiting for your surrogate. We rely on our colleagues to find an ideal surrogate for us, a woman between 24 to 42 years of age, healthy, no medical problems, body mass index less than 32, a good home structure, good supportive family. We have to review all their medical records. We then invite them to our office. We do all the screening tests on them, psychological testing, analyzing the uterus with ultrasound, blood work for blood sugar, insulin, thyroid hormone levels, vitamin levels, infectious disease testing, urine toxicology for drugs and medications. Once all that testing is completed and we have the results and the surrogate's medically cleared, then Rich will complete the legal contracts. And once we have a green light from Rich and his team, then we move forward with preparing the surrogate's uterus with medications. That'll take about 2.5 to 3 weeks. We then typically thaw one single embryo, keep the remainder frozen, perform the transfer. We follow the pregnancy in the first trimester until 10 weeks. At 10 weeks, the risk of miscarriage falls to 1%. We refer your surrogate to her obstetrician gynecologist. At 10 weeks of gestation, we also send you an email outlining the testing in the second trimester that we recommend, because we want to continue to be vigilant. IVF pregnancies tend to be slightly higher risk pregnancies. So we want to stay vigilant the second trimester with screening, including ultrasound, blood work, to make sure that the fetus is healthy. And we follow you all the way. I mean, we're always available to you. I typically will communicate with you either via email with my copy or via WhatsApp. So I just don't want you to hesitate to reach out to me, my team, with any questions or concerns. But that typically is sort of the process of IVF and then transfer, and then all the way to the birth of your children.
Brilliant, thank you. Darlene, do you want to talk a little bit about surrogate qualification, matching criteria, insurance, which we know, I think you've got one of your colleagues.
We all hate insurance over here.
Yeah, and I think what would be a great topic, if possible, is around costs as well. What are the costs? How can we control the costs? Because as we know, this is an expensive process. What can we do to bring that down?
Okay, well, let's start with the IVF Center. No, I'm just kidding. I think the main point I want to make for an agency is that we are sort of the information gatherers at the initial stage. So we get the profile, we get the birth records, we get their OB clearance, their clear PAP. We get all of this. We do home visits. Right now, they're not home, they're by virtual, but we do background checks, criminal, civil. We do psychological evaluations. So we do as much as we can up front to where then we present it to Dr. Donishman, and he has the information that he needs to give a pre-approval. So we seek pre-approval before we even do a match. That's important to us. We don't want our clients to get involved with a surrogate, love her, and have Dr. Donishman say, no, this is not going to work. So that's our first step, is to make sure that we understand San Diego Fertility Center's criteria, and then we as agencies are supposed to be recruiting surrogates who will meet that criteria to give you the best chance of having your surrogate screened and passed. What we do in our matching is we talk about things like, what are your thoughts about prenatal testing, amnios? Do you want the least invasive versus do you want to go with amnio? We talk about what would happen if you have a split Dr. Donishman said, most clinics are going with single embryo transfers, but sometimes they split and you end up with two. And so fetal reduction is something we talk about. We talk about if there's medical issues with the child, what you would want. You know, of course, at the time you'll make your decision, but going into this, we want to have the surrogate and the intended parents to have the same basic thoughts about all of this. So we understand that when we do a personal interview with one of our parents who's interested in working with us, that's what we talk about. We talk about all of that so that we can match them with a surrogate, and that will mitigate, hopefully mitigate most of the risks of misunderstandings. And then we send that information to Rich Vaughn, who puts that into a contract. So, you know, we're disseminating the information and getting it to the proper people. But once their job is done, ours still continues. And we work with our clients throughout the entire pregnancy. Like Dr. Donishman, who has a list of testing that he recommends, we keep our parents informed each trimester of what to expect and help them through that. So our matching criteria is, we're a little stricter actually than Dr. Donishman, which surprised me. We usually will not accept surrogates who are over the age of 38. And that doesn't mean we won't. It just, that is our own guidelines, and we try to stay in a BMI under 30 or under. We know that there are exceptions made. And so if someone is a stellar candidate, we are not going to refuse her over that, but it was Dr. Donishman's decision whether he also thought that she was a stellar applicant. So for us, it's really a matter of getting to know our intended parents, getting to know what their desires are, getting to know what kind of communication level they want with their surrogate. And once we understand that, then my director, Rose, who has been a surrogate 5 times and has donated to numerous German clients, she is the one that will then take that information and she individually will match you. She doesn't just say, take the next one that comes up. She tries to match as many things that are important to you as possible. And so the vaccine is one of those new questions that we have to ask and try to find you a match for that.
Brilliant, thank you. I think a question that is a two-pronged question. One, the question has come through, what is the rate of embryos splitting from 1 to 2, 2 to 3, 3 to 4, for example? And what happens with double embryo transfer? Is that something that you, Darlene, you allow? I know that as a clinic we do it, but can we talk a little bit about the twins thingy? Dr. D, do you want to jump in on the rate of split, and then Darlene?
So yeah, certainly. I think the rate of split in IVF is roughly between 1 to 3%, meaning that you have one embryo that splits into 2. We don't know at which point in the embryo's life this happens. We can't identify that in the lab. There are no indicators in the lab that will tell us if we transfer a single embryo that single embryo has a potential of splitting into 2, but it happens at a rate of about 1 to 3%. And one thing to remember is that when a embryo splits into 2 and then we have an identical twin pregnancy, which means a pregnancy in the same sac, the rate of miscarriage actually with those pregnancies goes up to about 40%. So unfortunately, 40% of those pregnancies are lost before 11, 12 weeks of gestation. And of course, certainly one of the other worries is if we do transfer 2 embryos, that if one splits, now we are addressing a triplet gestation, which is a very, very high risk. And that's the reason why overall the recommendations is for a single embryo transfer, although as you alluded to this fact, we do sometimes on occasion do a double embryo transfer. I think in looking back, for example, the last couple of years, about 90% of my transfers have been single embryo transfers.
We do allow for double embryo transfers if the physician does. This is not something that we would make that decision. That really is a clinical decision, but we would allow that if the clinic does. There is a difference in cost, and also that goes back to the matching. If you want 2 embryos transferred, is the surrogate willing to take 2 embryos? What happens if both take? Is she willing to keep both of them? What happens if it splits? So there's a lot of scenarios that we have to work through. But when I first started, double embryo transfer was the norm. We did that all the time. And Dr. Donnerschman, I had one case where we had a surrogate get 2 embryos, both of them split, and we ended up with 4. And they decided to go ahead and reduce because they were in the same sac, of course, so they ended up reducing one set of the twins, and the other set was born and they were fine. But what we're talking about with twins is the potential for more complications for the surrogate, maybe more bed rest. You know, maybe she has to have more child care. We have to get her more help with meals, and that we will help with that, but that is a very real possibility. The risk of an early birth, if you're an international family dealing with this pandemic, and you know you're dealing with twins, your babies could be born before you could get here, just because of the travel restrictions. And so we have to talk about what happens in that case and who's going to take care of the children. Cost-wise, surrogates are paid more if they have a twin pregnancy. It's between $7,000 and $10,000 for an additional fetus. Their expenses, monthly expenses increase. Their allowance for clothing increases because they're, going to be bigger sooner. And so there are cost variants that come with that. Insurance is another thing. Most people don't have insurance that covers the children. Fortunately, my German clients have been able to get insurance that covers their children. So we've not really struggled with people having to pay a lot of money, but NICU is what, $10,000 a day per child. And so, when you think about how many embryos you want to transfer, it's not just, what's safest for the surrogate. There is a financial component to this as well. So we've actually done an analysis and found it's less expensive to do 2 separate surrogates with single embryo transfers. And so we do allow for that as well. We will match people with 2 surrogates. And I know Dr. Donnerschman will work with people who work with 2 surrogates. So.
Okay, so many questions have come through, one that I know the answer to. So just, when I started doing this, so I have twins, Rich has twins, people basically had twins because we weren't necessarily educated on the risks associated with it. I did the numbers for STF. Well, I didn't have you as a doctor, exactly. You weren't as widely popular now, I'm seeing. Over the past 4 years, I've noticed the number of twin pregnancies at SDFCs dropped. It started around 14% years ago. Last year, we did 2%.
Wow.
So that 2% of our clients did a double embryo transfer. And that I fundamentally believe is around the education, around the risks for the surrogate, a risk for the children, the financial risks, all those different bits and pieces.
Yeah.
Question, how high is the rate of success, i.e. the success rate, Dr. D?
So typically, once the embryos are created, we have means by which we can assess the quality and the grade. We have a classification system actually based on a paper we published many years ago. If we transfer a good quality embryo and the uterus has been prepared, and of course the surrogate has been approved, then the rate of pregnancy should be about 81%. That's been my experience with my embryo transfers over the last several years, about an 81% chance of pregnancy and delivery with the transfer of a single good quality embryo. Once the embryos are created, and I'm in touch with my intended parents, throughout the whole journey, we will have a consultation together on Skype, on Zoom, and we will go over and review all the embryos that have been generated, their quality, what is their rate of pregnancy if we transfer a single embryo, this particular embryo versus another. So it's something that we have a discussion about And of course, when you transfer two embryos, the rate of a twin pregnancy, again, is going to be dependent on the quality of the embryos. Sometimes we have patients who are older, heterosexual couples are going through IVF, and let's say the woman is 40 years of age. If you transfer two embryos from a woman who's 40 years of age, the rate of pregnancy is going to be different, and the rate of twin pregnancy is going to be very different. And let's say a younger egg donor, where we're transferring two good quality embryos, with the rate of twin pregnancy could be 70% or higher.
I have a question for Dr. Donishman that I think that the audience would really appreciate knowing, because it was fascinating to me. I just saw a study, and I don't know if you presented it or not, Dr. Donishman, but the rate of pregnancy for single embryo transfers can sometimes take more than one transfer in order to accomplish that rate. So I saw on average it can take 2, maybe even 3 single embryo transfers to reach the percentage that you're talking about.
It all depends on the quality of the embryos. Certainly, I think with egg donor conceived embryos, it should be very high quality, because certainly the egg donors that we work with are screened specifically for genetic, for family history, and for egg quality parameters, making sure that they have an adequate supply of eggs, an adequate number of good quality eggs in their ovaries. But the expectation that we have is, if we transfer a single good quality embryo that's been deemed, for example, the highest classification that we have, that the rate of pregnancy that we have seen in our clinic has been roughly around 81%. In fact, I think in 2020 it was closer to 82%. In 2019 it was about 81%. That's the rate, but all depends on the quality of the embryos. Because the surrogate is going to have been vetted and screened, and we know that the uterus is going to be in ideal condition prior to transfer, that is not as significant a criteria, because all surrogates are deemed to be healthy, fertile, and their uterus is ideal prior to transfer. If the uterus is not ideal prior to embryo transfer, we cancel the embryo transfer.
Right. Again, there are questions that are coming in. We will get to you. Don't panic. Rich, sorry, I'm very conscious of the fact that you're just sitting there like, the legal part. Do you want to talk a little bit about egg donation legals, surrogacy legals? You've done birth certificates a bit and passports a bit, but a little bit more info on the legal side of things.
Sure. And I'd like to kind of touch on your other question earlier about costs and how do you get them down. It's hard to get them down significantly, but what you can do is to help try to control your costs. And you've heard all about the screening and the vetting that's done at the agency level and at the medical level, the background checks, the psychological screening. You've got to do that right, and that's not an area where you want to cut costs. Doing all of your proper research, your vetting, your screening of all of your team, and getting a good team in place as well, this is going to help keep you from having to possibly reboot and do over and end up costing extravagantly more. Now, we can never guarantee that things work the first time, but that's the way to really help keep things under control. That's how you keep your costs controlled. I will say, though, just as a quick plug for the lawyers, the legal fees are the lowest among all the professionals. But from the legal point of view, once you have your egg donor and she's been medically and psychologically cleared and is ready to go, you have to get a contract in place. So we will put that contract together. It's template oriented, but it is customized to each match, and those details come to us from the donor program. And then the parents get the chance to look at the contract first, then the donor looks at it with her attorney. She will have a separate attorney. That contract eventually will get finalized. There may be some negotiations. It's usually low-level negotiations. It's not a fairly intense negotiation process, and the contracts can take, on average 2 to 3 weeks. And then we send a legal clearance letter to the doctors so the doctors know that they can go ahead and get the donor started on her injections. There is a component to this contract that requires that the parents put the fees and expenses into an escrow account. You have choices on where that escrow account can be held. Attorneys can hold it. Some agencies do it. and some clinics do it. So you'll have to sort of suss that out depending on where you find your donor. And that's the process with the donor. The contract basically says that the eggs belong to the parents from the moment of retrieval. They get to decide what to do with them, typically fertilize them, create embryos, and then any resulting children belong to those intended parents. And that's typically all you do with the donor. The process with the surrogate is the same. You need to have her screened and cleared first, and then once she's approved by the doctor, then you can start the contract process. It's, again, we draft it according to the details provided to us by the agency program, and parents see it first, then the surrogate gets to see it with her attorney. We have some negotiations possibly, then we get the contract finalized and signed and send a legal clearance letter to the doctor. So in the surrogate's case, they also have legal clearance, and at that point, once legal clearance is issued, they can start the surrogate on her injections. That contract takes usually a little bit longer, doesn't have to, but usually on average about 3 to 4 weeks. So that process is rather smooth for the most part. In the surrogacy contract, we of course establish all the fees and expenses. We talk about insurance. We talk about the issues of abortion and reduction and what the parties have agreed to before they go forward together. We talk about the escrow account, and of course, from the big picture perspective, the contract establishes that the intended parents will be the legal parents, and that surrogate will cooperate with them in doing whatever they need her to do, sign whatever documents, whatever's needed to confirm, protect, and establish their parental rights. So that's what the contract covers in very broad brushstrokes. But you have to go further with the surrogate. You're not just done at the contract stage. We do recommend that the parents sign guardianship documents to designate who they would want to care for the child if something happens to them during the pregnancy, or in the case of COVID, if they're unavailable temporarily. We also want the surrogate to appoint the parents as guardians of the child during the pregnancy, because the contract does not make the parents the legal parents. That we have to go to court to do that, and that comes a little bit later. So in this document, the surrogate will give the parents a healthcare power of attorney, so they have the ability to talk to the OB and to view the pregnancy records and be present at healthcare visits in person or electronically like this. And also that if they need some authority to make a medical decision, they have her authority to step in and be involved in that process, as long as the decision isn't going to put the surrogate in any harm's way, of course. And then the final step of the legal process is to go through a court process, to have a court issue an order saying that the intended parents are the legal parents and that their names go on the birth certificate. That's a process that we start at 14 weeks of pregnancy, and we typically end up with a court order. In most states, it's a pre-birth court order signed by the judge, typically on or before the 28th week of pregnancy. In most of these court cases, the parents do not need to appear in court, they just need to sign documents. And we submit them to the court as a fully agreed petition. We've never had a case not receive a court order. These are pretty good files for the judges to get. They're usually family law courts dealing with people who are not wanting custody of their children or fighting or divorcing or whatever. So these are happy cases for the judges. So everyone's signing these documents saying they're in full agreement. Once the court order is signed, even though, and I should say that the pre-birth court orders are not effective until birth. They're signed during the pregnancy so that it becomes effective immediately at birth. It's nice to have it out of the way, but it's not effective until birth. But we still make sure that the hospital has a copy of it on file long before the birth. We have a conversation with the hospital to make sure that they are aware that there's a surrogacy birth coming up, that the intended parents will be the legal parents, and that if they have questions, they can call the attorneys. And if they need other documents, they can call the attorneys. That way, when the birth occurs, everything should run very smoothly at the hospital. And then we've already touched on the birth certificate and passport. Just skip that for now.
So actually you touched on one of the questions, and maybe Darlene, you can help with this. What is covered by health insurance? What is not covered by health insurance? And what health insurance does one need?
Boy, sadly in California and in the US in general, that can change in a moment. So what we do as an agency is we work with a couple of insurance brokers who know which plans are surrogate friendly. And That is, Rich just sighed a little bit. I'm not sure why. But
No, I'm dying to jump in.
So, some surrogates already have insurance in place, but that's becoming more and more rare that they have insurance that will cover surrogacy. If it does, they will generally have a lien right to a certain amount of money. They base it off of the surrogate's compensation, generally speaking. And so that is often, it has to be signed before the hospital will even take the surrogate as a patient. We try to get this insurance in place. The cost is, if you can get a surrogate-friendly insurance plan, then you're looking at approximately $15,000. Wouldn't you agree, Rich? 15 is kind of a minimum. That includes the monthly payments for the and the copays, and the deductible generally runs about $7,500. That is on the low end, and if we can find the perfect policy, that's what we try to get. But we have had some insurance midstream, mid-pregnancy, change their minds, and that's where working with a good insurance broker is very helpful, because they were able to help us get into a new plan. There are some more expensive plans. Bridge the Gap is one. The Lloyd's of London is another one. And because in the US we have enrollment times, we have to have insurance in place before most places it's January. The end of January is kind of the maximum. But there are a few states where pregnancy itself is a trigger to be able to get insurance. So that's really, something that we're looking closely at, which states have that provision made. But the insurance is the most expensive. I would say you're looking 15 for a singleton, Rich, maybe 25 through Lloyd's of London.
Oh yeah. Oh, for singleton? Yeah. No, the premium for a Lloyd's policy would be in the range of 12 to 15,000, and then you self-fund the deductible for twins or for singletons at 20 or 25,000, and then Lloyd's will pay the medical bills with the money that you've given them. And then once you've reached that maximum, they'll cover everything else after that up to a preset limit, usually more than enough to cover the maternity expenses. So, to your question, Richard, of how to, control costs in an ideal world, it's not always possible, but in an ideal world, you find a surrogate who already has insurance that does not exclude surrogacy. Maybe she has it through work. Maybe she has an individual policy. Maybe she has it through her spouse's work. But the policies will outline for you what's the cost, what's the premium, and then it also will define all the uncovered expenses and put a limit on that. There's a thing called out-of-pocket expenses, and the policies will typically define for you the annual out-of-pocket maximum. So when people ask me what's covered, what's not covered, I mean, the way that the Affordable Care Act works is there are no pre-existing conditions that would exclude coverage right now. Lloyd's will have some, by the way, but not as if there's stuff that's not going to be covered by insurance. There's usually just an out-of-pocket contribution that the covered person has to pay, like a copay or a deductible when you have a test, or when I go to the doctor, I have a copay of $35 every time I walk in the door. That's an out-of-pocket, but that policy will define the maximum per year. So that will help you gain a sense of your exposure.
So this is covering the surrogate while she's pregnant and up to birth, correct? Because I'm confused.
Yes.
That's what I was just going to say, is that we're talking right now about insurance that covers the pregnancy. And in the case of singleton pregnancies, we rarely would ever go over the maximum, or most times we don't even reach the full deductible amount of $7,500 to $10,000. In a healthy singleton pregnancy, that's what the goal is, and that will minimize your financial responsibility. When we get into complications, that's a different story, and then we could reach the maximum pretty quickly. The expensive part is after the birth. that's where the expense comes in. And German families are lucky to be able to buy a policy that will cover the child. They oftentimes have to pay and get reimbursed, but many countries don't have anything to offer parents, and they have to come and they cash pay for the care of the child.
So on that, if there are, so one of the questions is specifically related to that, if they've been unable to get an insurance in Germany for the post-birth, what can they do?
Rich, before you answer that, I just want to say what we find is that our parents, these depends on the policy, of course, but a lot of times the post care of the child will be covered for 48 hours. So if it's a healthy child that's not in the NICU, in the intensive care unit, then the cost is usually covered, or they might ask for $1,000 a day. And most parents can cash pay for that. So, and they usually will also provide a well baby check, which is the check that you need to do to make sure the child is safe and healthy enough to fly, to go back to Germany or wherever the child would be going. A lot of times that is included in the surrogates policy. So it's when it's more complicated, twins in the ICU, early, very premature birth, that's when it gets into more financial problems. But the hospitals are also good, thanks to people like Rich Vaughn and other attorneys. They will negotiate with families and, for a cash pay situation. So sorry, Rich.
No, it's okay. No, I think, again, back to the issue of cost, again, if you're focusing on safety and trying to control the process as much as reasonably possible, you do the single embryo transfer, you minimize your chances of NICU bills and extraordinarily expensive baby bills after the birth. Now, best laid plans of mice and men, right? So you can't always work the way you want it to. So having some sort of insurance plan or plan to cover the baby's cost is important. So for those that can get private German health insurance that they can use to cover the baby's cost, that's great. If they can't, there are other options. I mean, options are sometimes limited to someone's creativity, but let's just say Allianz is another product out there that's available. It only covers a singleton, and you have to get that policy in place to cover you as the parent first, 8 months prior to the birth. And when the birth occurs, you add the child to it. And then I think that their coverage is in the range of $1.5 million of coverage for $7,000, $8,000 of cost. There's another plan that used to be called Jiban, which is now Great Morning something or other. I think it covers twins. So the important thing is to talk to a broker.
Right.
Talk to a broker early on in the process and look at what all of your options are. And do that early in the process.
In fact, if you go on to, this is a shameless plug, SDFC has a YouTube channel where this will end up. On that channel, I have actually done a webinar with a lady called Virginia Hott, and she is the insurance broker that we all know and we all love. And she walks you through applying for insurance for the newborns. So go have a look at that. It's on there, and that can also answer any of your questions. But failing that, email me. I'll introduce you to her, and you can go through that. One of the other questions, Darlene, is there a policy that the surrogate has to be unmarried? If so, why is it?
Okay, well, that's actually probably more of a Rich question, but I can tell you that we recruit surrogates purposely who are unmarried, and it has to do with ease, I guess, Rich, of proving that or not proving that the surrogate's spouse is the biological father. So by an unmarried surrogate, we're dealing with one less person. A number of our clients lately have been using married surrogates and not having any issue whatsoever in bringing child's home.
There was a time a number of years back where, for German parents in particular, it was important for the private insurance piece for the baby that they be matched with an unmarried surrogate, because the presumption under the law everywhere in every country is that the person who gives birth is the mother, and if she's married, her spouse is the other parent, or her husband is the father. So for purposes of insurance, which they would need to have covered immediately at birth, you know, if there's a father or a husband to the surrogate, then he would be the father under German law. So for the insurance, they wanted unmarried surrogates. But what's been happening in the last couple of years is that we've been having the clients talk to their private insurance company, and we've also talked to the German consulate here in the US. And they've said that if you have a pre-birth order, or you have the surrogate sign an acknowledgement of paternity at the German consulate during the pregnancy that says, I'm carrying, but he's the father, the real father, then the private insurance will acknowledge that for purposes of providing coverage through the father, the German father, at birth. So, and that can be the situation you have even with a married surrogate. So as long as there's a pre-birth order that would apply to either a married or unmarried surrogate, or an unmarried surrogate goes to the consulate to sign the acknowledgement, then they should have coverage under their private German health insurance at birth.
But if you want an unmarried surrogate, that is something that an agency should strive to help you with, because this is about your risk assessment. And if you just feel that that's more important and lessens any stress for you, then that is something you can ask for as well.
Exactly. And again, if you go back to our webinars, I've done one with a German lawyer called Thomas Oberhauser. I asked him questions in English, and mein Deutsch ist nicht gut. Therefore, he replied in German. I really don't understand what he was saying. But one of the questions I asked him was about this, and to what Darlene and Richard just said. It was an insurance issue. The law in Germany changed as well, and I think some people appealed it. And so, again, go to those webinars, have a look at those, because we have spoken about different bits and pieces, okay? Got one question, which actually is a really good question. How long is this journey going to take? I'm going to ask all of you.
About 18 months.
I can give you my perspective on this. Our goal is 1 year from the time that people decide to work with us. And we have that broken down into 3 months for getting the surrogate prepared and ready for the embryo transfer, which that includes the psychological, the getting the records, having Dr. Donishman approve them, and then of course the 9 months of pregnancy. So that is our personal goal. Most times we are able to meet that because we have very successful doctors that we work with who have 81% success rates. And so it usually is a year. If it's longer than that, if the first transfer didn't work, then you could be looking at an additional maybe 2 to 3 months for the surrogate to be prepped again and ready to accept another embryo transfer.
Yeah, I think
I would say if you're adding an egg donor to the mix here, then you're looking at closer to maybe a year and a half, give or take. So build, you know, as a parent, you go through this, build yourself a little cushion so that you don't get your feelings hurt when you have a small delay, because there will be some, you know, it's not a completely perfect process every single time. It works really well and goes very smoothly most of the time, but build some of this into your expectations so you're not, you know, damaged every time you get a small delay.
Right. And trust your team. Like you said earlier, Rich, we're all here for your success. And so if you do have little blips along the way, if it's medical, I can tell you Dr. Donishman is going to really give everything he has to make that, you know, fix that problem or whatever. For us, it's the same thing. As an agency, if there's a blip along the way, we will continue to work very closely with you and the attorneys, same thing. You know, so there's always going to be something. This is not a perfect science, and so you can expect some ups and downs, but if you have a good team in place, they can help manage all of that and get you through it in an easier way. So
I don't have any more questions through on my side. Do you guys have any on your side, just in case they've come through and not onto my question? No? Okay.
Yeah.
I think we've covered quite a bit. Do you guys, is there anything else that you feel that we need to go through? And guys, this is the last call, right? So any more questions, please send them through. Darlene, Rich, Dr. D, anything that you think we haven't touched on?
We've touched on this, but I just think it bears repeating that this process takes planning, it takes patience, it takes calm. You have to just not panic. There will be obstacles, you will overcome them. Plan, rely on your team, and put a good team together. And I say this all the time, it's a little bit like a construction project. If you've ever been involved in construction, you may have the best architectural plans in the universe. You may have the best team in the universe, but somebody might break a pipe or knock down a wall, and then there's a problem they find behind it, and then they solve it, and then you move on. So just be prepared, be patient, stay calm.
Mm-hmm.
And I to echo, I think Rich's words is, you know, organizing, good organization, planning, having gone through fertility treatment ourselves, you know, having a team together that is reactive, that is always in communication with you, always available to guide you, to support you, because there are going to be stressful moments where you're going to need a helping hand, where you're going to need support. And I think you have a team here that's really capable of that and passionate about that. So I think that that's one of the key components. You know, you talk about clinics, doctors, attorneys, agency owners, agencies, and, you know, their success rates and the reputation. The reputation is really also built not on just success, but on how they've taken care of and how they've supported intended parents throughout the years.
Right.
So I think that's what I want to say. And of course, eine schöne Weihnachtsfest as well.
Yeah, frohe Weihnachten.
Showing us up, Dr. Donishman. I am the parent of a surrogate daughter. We were, as far as we know, number 3 in the world to do gestational surrogacy. She is now 30 years old and has a baby of her own. And I'm going to get emotional. It's worth it. Whatever you are dealing with, and don't give up. Don't give up your dream. This is, it takes work. It does take effort. And, you know, we're here to support you because we're parents who have gone through this. I helped Rich. He's not telling about that, but you know, I feel like his boys are my nephews or something, you know, my grandchildren. And so don't give up, and you know, put together a good team, trust in your team, and communicate really well with all of us, your wishes, what's most important to you. And we're going to do our best to be able to meet those, but don't give up. That's really what I want to say.
And I'm going to cry purely and simply because it's the last webinar I'm doing of 2020, and it's so exciting. But to that point, right, we are here to help every single person on this webinar. If you want contact details, email me. I'll forward them to you. This is a journey. I hate that word, but it really is. And our passion is to make your dream come true. And we really will do everything that we can to do that. And to answer the last question that's come in, yes, you will be able to see this recording. I'm going to put up on our YouTube channel that you can go on to YouTube, SDFC YouTube. It'll be there and you can watch it. So
everybody go and like it and click on it. So this one becomes the best one of the year.
Isn't it actually pronounced YouTube?
YouTube. No, I didn't. Anyway,
now the UK has become a vassal state, you know.
Exactly. Have a wonderful Christmas, everybody. Frohe Weihnachten, and let's just hope 2021 is better, huh? Anyway, take care. Thanks a lot. Bye-bye.
Schöne Weihnachtsfest.
Being here.